Hi, this is Dr. Bonarigo, and today we're going to be discussing diabetes and its dermatological manifestations and complications. So the majority of the patients, as you know, that we see in the clinic do have diabetes. So this topic is pretty important for you guys to know that diabetes does manifest itself in the skin. It's important for you to be able to recognize and treat these patients accordingly based on what you see. So about a third of diabetics have skin manifestations, and it may in fact be the first indicator to these patients that they're diabetic. Um, a lot of the specific diseases that we're going to talk about in more detail have pathophysiologies that are relatively unknown or still being studied. But for the most part, these lesions are believed to be secondary to metabolic effects on microcirculation and changes in skin collagen. So again, recognizing the lesions is key to treatment and prevention. I also want to note that we're going to be discussing various types of diseases of the skin, but in specific, more of the autoimmune type skin disease manifestations are more commonly seen in type 1 diabetics versus bacterial skin infections, which are more commonly seen in type 2 diabetic patients. So periungual telangiectasias are present in up to 49% of people with diabetes. These arise in the nail beds of diabetics after loss of capillary loops and dilation of remaining capillaries. So again, there's a microvascular component going on in the pathophysiology. They typically present with nail fold erythema, which is seen here in the picture above. Dilated blood vessels, which are visible to the naked eye, which you can also see here and also here. These patients will typically have fingertip tenderness and thick, ragged cuticles. There is no treatment that's necessary for this condition. Necrobiosis lipoidica is a rare chronic granulomatous disease of the skin. It's present in about 0.3 to 1.6% of people with type 1 diabetes, and it's pictured here to the right. It's more commonly seen in women versus men, and this is a cutaneous marker for diabetes. Its pathophysiology is currently unknown, but could be related to a number of things, including localized trauma, microangiopathy, immunoglobulins, and fibrin deposition, as well as metabolic changes. The presence or progression of necrobiosis lipoidica does not correlate with how well the diabetes is controlled. Necrobiosis lipoidica, again seen here to the right, will present typically in the pretibial skin, and you will see non-scaling plaques with a yellow atrophic center, surface telangiectasias, and an erythematous or violaceous border that may be raised. They can be multiple and bilateral, and they can demonstrate the Kebner phenomenon, which means that these lesions can spread just from trauma to the skin. These lesions may ulcerate spontaneously or from trauma, and ulceration can occur in up to 35% of cases. Treatment for patients with necrobiosis lipoidica involves counseling on, number one, the avoidance of trauma. It can also be given topical steroids or intralesional steroids at the active border, as well as antimalarials and photodynamic therapy. Next, bullosus diabeticorum, which is pictured to the right. These are also known as diabetic blisters, and they are a distinct, spontaneous, non-inflammatory blistering condition of the acral skin. They are present in about 0.5% of diabetic patients, seen more in men with long-standing diabetes and peripheral neuropathy. The cause is unknown, but it's likely multifactorial, again related to microangiopathy, trauma, poor glucose control, and possibly UV exposure. There are typically three types. of bullosus diabeticorum, the first being a common type. These are clear, sterile blisters on the tips of the digits, and they heal without scarring and atrophy. Next is hemorrhagic bulla, and these are blood-filled. These are healed blisters. When these blisters heal, they may show scarring and atrophy. And lastly, there's multiple tender, non-scarring blisters in sun-exposed areas. And those are the 3 different types. Typically, in general, bullosus diabeticorum will be clear bulla on non-inflamed bases. They look like burn blisters. They tend to be asymptomatic, although mild discomfort or burning has been described. And the lesion can range from a few millimeters to a few centimeters. Typically, in terms of treatment, these lesions resolve on their own in about 2 to 5 weeks, so just leave them alone, even if you are tempted to lance them. You always want to consider infection prevention with this type of blistering condition. If the bulla become too large and symptomatic for the patient, you can aspirate it using a needle, but you want to leave the roof intact to protect the skin barrier. You don't want to lance these using a blade. Saline compresses can also be used for symptomatic relief. Vitiligo is a chronic autoimmune disease, and as I said before, autoimmune diseases typically manifest with more so with type 1 diabetics, which is seen here with vitiligo. It's prevalent among 1% to 7% of all diabetic patients and only 0.2 to 1% of the general population. The pathophysiology is unknown, but again, thought to be multifactorial with a possible biochemical, cytotoxic, neural, autoimmune, and genetic factor. These patients will present with hypoachromic macules surrounded by healthy skin, whose size ranges from a few millimeters to large extensions, pictured here to the right. Biopsy, although not indicated, this is typically a clinical diagnosis. Biopsy is definitive. It will show loss of epidermal melanocytes. Treatment for vitiligo is based on the size and spread. Small and localized lesions are treated typically with topical corticosteroids, but widespread vitiligo will most likely need phototherapy involving narrowband ultraviolet light B. Lichen planus, pictured in 2 forms to the right, is an inflammatory keratotic dermatitis with an unknown origin. It can be confused with lichenoid reaction to drugs. It will present as polygonal erythematous flat lesions, seen better in this picture here below. However, oral lichen planus, pictured above, will present with a white lacy pattern seen on the tongue. Histologically, you will see numerous eosinophils, perikeratosis, and perivascular inflammation around the mid and deep dermal plexuses with lichen planus. Treatment is with topical or intralesional corticosteroids, systemic glucocorticoids, or phototherapy. Diabetic yellow skin and nails is prevalent in 40% of diabetic patients with type 2. It's more common in elderly patients, and it's most evident in the distal end of the hallux. It's caused by hyperkeratinemia and protein glycosylation end products. The picture here shows a normal thumb versus a patient with diabetes and their thumb, and you can see the yellow discoloration. Diabetic thick skin is thickening of the skin that will occur with disease progression. It occurs in 20 to 30% of diabetic patients, regardless of the type of diabetes, and it's a marker for retinal microvascular disease, also known as retinopathy. It's believed to be caused by an increased stimulation of insulin and non-enzymatic glycosylation of collagen, which causes increased collagen cross-linking, rendering the collagen fibers resistant to degradation by collagenase and leading to increased amounts of collagen. The thickness of skin in a patient can be measured on an ultrasound. And there are three forms of this diabetic thick skin. The first form is a general form, and it's asymptomatic, and you can measure the thickness. The second form is thickening of the skin, but it's specific to the fingers and the hands. And the third form is called diabetic scleroderma, and it's localized typically to the upper back. It can have a peau d'orange appearance. So the second form of diabetic thick skin is thickening of the skin on the dorsum of the hands, which occurs in 20 to 30% of all diabetic patients. It will present with pebbled knuckles or Huntley papules, which are multiple minute papules grouped on the extensor side of the fingers, on the knuckles, or on the periungual surface. These patients may also present with stiffness of the metacarpal phalangeal and proximal interphalangeal joints, which can progress to limit joint mobility. Again, here there are two images which show the pebbled knuckles or Huntley papules, as seen in diabetic thick skin. Scleroderma diabeticorum was the third type or form of diabetic thick skin, and these patients will present with thickening of the skin on the posterior neck and upper back, which occasionally extends to the deltoid and lumbar regions. You'll also see a peau d'orange appearance of the skin, and these patients may often have decreased sensitivity to pain and touch. Here is a picture of Scleroderma diabeticorum on the right. In the upper back region, you can also see a peau d'orange appearance. Again, these are often asymptomatic. However, neck and back pain may occur. Treatment is with steroids and phototherapy. Again, pictured is the third form of diabetic thick skin, Scleroderma diabeticorum. And again, it is localized to the upper back and neck, and you may have a peau d'orange appearance of the skin, and it's typically asymptomatic. Acrocordons, also known as fibroepithelial polyps, skin tags, or soft fibromas, are typically related to familial history, obesity, and hyperinsulinemia. The pathogenesis of acrocordons is caused by insulin resistance, which leads to hyperinsulinemia, which will cause activation of insulin growth factor receptor, which will cause keratinocytes and dermal fibroblast proliferation. If you see more than 3 skin tags that involve multiple body sites on your patient, this can be a marker for diabetes. These are benign lesions, but can become symptomatic with abrasion or necrosis, and typically it's more of a cosmetic issue for people. The most common locations are the eyelids, neck, axilla, and groin. Acrocordons are diagnosed clinically. However, if malignancy is suspected, they can be biopsied and sent for histological testing. Treatment, again, this is more of a cosmetic issue for people to have it removed, or if it's irritating, they can be removed. But they can be removed via excision with forceps, fine grade scissors, cryosurgery with liquid nitrogen, or electrodesiccation. Diabetic dermopathy, also known as pigmented pretibial patches or shin spots, is very common. You'll see this in a lot of the diabetic patients. It affects 50% of all diabetic patients, and it's actually the most common skin lesion in diabetics. It's usually benign in nature, and again, the pathogenesis is unknown, but it's associated with other microvascular complications, and the pigmentation is due to hemosiderin deposits from microvascular disease. More than 4 or more lesions are indicative of diabetes, and it is associated with the length of disease and poor glycemic control. So the longer a patient has been diabetic and the less controlled they are with their diabetes, the more likely they are to have this type of skin manifestation. And seen here on the right, the patient's going to present with multiple asymptomatic round, brown, dull red to pink papules or plaques, which are usually less than 1 centimeter, but can be up to 2.5 centimeters. Usually they occur on the shins in a bilateral asymmetrical distribution. And the intensity of the pigmentation corresponds to the degree of atrophy. So the darkest lesions are the most atrophic. There is no current treatment for diabetic dermopathy, and these lesions heal and disappear within 1 to 2 years on their own, leaving atrophic hypopigmentation at the site of their origin. Acanthosis nigricans will be present in up to 74% of obese adult patients. It is a prognostic indicator for developing diabetes type 2. Its pathophysiology is related to insulin resistance. High levels of circulating insulin binds to insulin-like growth factor receptors and stimulates growth of keratinocytes and dermal fibroblasts. Clinically, you will see hyperpigmented, velvety thickening of skin folds, also known as intertriginous areas, presenting predominantly in the neck, axilla, and groin areas. These lesions are generally asymptomatic, however they can be painful, malodorous, macerated, or pruritic. The dark color is due to thickening of keratin containing superficial epithelium. Pictured here is a patient's neck and the velvety thickening of the skin folds. This is a patient's axilla, and you see again the presence of the lesion of acanthosis nigricans. So the treatment for acanthosis nigricans is to treat the underlying cause. It is reversible. The patients that are asymptomatic do not need treatment. You can also use ointments with salicylic or retinoic acid to reduce the presence of thicker lesions. And Accutane has been shown to improve the condition, but it will recur when the drug is discontinued. Acquired perforating dermatosis, seen to the right, has a strong association with diabetes and chronic renal failure. The pathogenesis is unknown, but defective differentiation of the epidermis and dermal epidermal junction secondary to alteration of glycosylation is believed to be the pathogenesis seen in patients with diabetes. These lesions will present typically measuring 2 millimeters to 10 millimeters, umbilicated, dome-shaped papules, and nodules with a hyperkeratotic plug. They're commonly seen on extensor surfaces. They're pruritic, and kebnerization may occur. Typically, they're treated with topical keratolytics, topical and systemic retinoids, topical and intralesional steroids, and oral histamines to calm the pruritus. Again, pictured is the acquired perforating dermatosis. Calciphylaxis is a rare life-threatening syndrome of vascular calcification. It predominantly affects end-stage renal disease patients on dialysis. Its pathogenesis is believed to be related to calcification and occlusion of microvessels in the subcutaneous adipose tissue and dermis. These patients will present with excruciatingly painful ischemic necrosis, and the pain may even precede the skin lesions. Early lesions will appear as the picture here seen to the left as violaceous, painful, plaque-like subcutaneous nodules, indurations, or levita reticularis. These can progress to ischemic necrotic ulcers with eschar once vascular thrombosis is advanced. The lesions develop in areas with greatest adiposity, and they're most commonly seen on the distal lower extremity. Prognosis for these patients is poor. Impaired wound healing infection of the skin will lead to progression and cause sepsis. Treatment for these patients is mostly focused on analgesia, wound care, And of course, consultation to other specialists, the dermatologist, vascular surgeon, or even a general surgeon should all be involved in these patients' care. Pictured here is calciphylaxis at a further progressed stage where you can see eschars present and less of a violaceous border. Eruptive xanthoma is a form of lipid deposits in the skin that typically indicate hypertriglyceridemia and hyperglycemia. These skin lesions often arise when a patient's triglyceride level is greater than 1,000 milligrams per deciliter. Typically, these patients will have crops of discrete or confluent domes with waxy yellow centers with an erythematous halo. They appear on the buttocks, extensor surfaces of the extremities, and flexural creases. They can be itchy and even painful. The diagnosis, again, is made clinically. A biopsy is not always necessary, but a biopsy is definitive. And you can also diagnose these patients by obtaining fasting lipid levels at presentation. Typically, patients with eruptive xanthoma will have this condition resolve spontaneously over a few weeks. And they can also lower the triglyceride concentration with diet modification and systemic medications, your statins. Rubeosis faciei diabeticorum is a common skin manifestation associated with new diabetes. The pathophysiology is unknown, but again is believed to be associated with a microvascular complication. The appearance of rubeosis faciei correlates with poor glucose control, and typically these patients will present as seen here to the right with flushing to the face. Treatment is strict glycemic control. Of note, in a study of 150 participants comparing facial redness association with diabetes, it was seen that 59% of patients with diabetes had markedly red faces compared to slightly red or not red, 21 and 21% respectively. Granuloma annulare is a rare, benign, and self-limiting dermatitis of the pretibular regions and the extensor surfaces of the limbs. Association between granuloma annulare and diabetes is sometimes controversial. Most cases of localized granuloma annulare are diagnosed in patients before 30 years of age. Incidence is highest in women with a ratio of 2 to 1 over men, and again, the pathogenesis is unknown. Granuloma annulare will mostly affect the areas of the that are exposed to trauma, including the backs of the hands and feet, fingers, elbow, arms, and legs. It's usually asymptomatic, but can cause pruritus or a burning sensation. It presents as erythematous to flesh-colored papules coalescing to form an oval or ring lesion. The cutaneous lesions are like Microbius lipoidica, but without causing atrophy of the epidermis. Treatment for granuloma annulare is self-limited and asymptomatic. Treatment is usually not necessary. However, if these patients are symptomatic, you could consider topical steroids, intralesional steroids, isotretinoin, dapsone, antimalarials, and phototherapy. There are 4 types of granuloma annulare that we're going to discuss. Type 1 is localized. It is the most common form. It's seen in 75 to 93% of cases. 50% involve a single lesion, and these are going to be an initial lesion that is asymptomatic flesh-colored papule, as seen here in the top photo. It infludes centrally to form an enlarging annular lesion up to 5 centimeters in diameter. It's typically found on the lateral or dorsal surfaces of the hands and feet, and over 50% of these patients will have spontaneous resolution within 2 years. The next form is a more generalized form, and that affects middle-aged or elderly patients. This is in 80% of cases. These will present as 10 or more annular plaques or multiple symmetrically distributed papules on the arms, neck, upper trunk, and less often the legs, pictured here in this photo. In contrast to the localized form, these lesions may persist for 3 to 4 years or longer. Type 3 is known as subcutaneous, and this is most commonly seen in children under 5. They present with asymptomatic subcutaneous nodules on the hands, scalp, buttocks, shins, and periorbital skin. The condition is self-limiting and does not appear to have any systemic associations, and diagnosis is made with an excisional biopsy. These lesions may resolve spontaneously or may recur after excision, and subcutaneous form is seen here. Type 4, also known as perforating, is seen here in this picture below. And what you see is 1 to 4 millimeter papules with a central cluster scale with or without an umbilicated center. This is a localized form found on the upper limbs and the pelvis. However, it can also be in a generalized form, which is more common, and it's present on the abdominal area, trunk, upper, and lower limbs. Cutaneous infections associated with diabetes, you're going to see these very commonly. Skin infections occur in 20% to 50% of diabetic patients, and again, your cutaneous infections are more likely to be seen with type 2 diabetics. They can be associated with poor glycemic control. Diabetics are at increased susceptibility to infection because of their poor microcirculation. They're at higher risk for peripheral vascular disease, peripheral neuropathy, and they then have a decreased immune response to fight these infections. Candida infections are typically seen in these cutaneous infections as the infectious agent in cutaneous infections. Hyperglycemia favors Candida proliferation. A Candida infection can be an early sign of undiagnosed diabetes, and typically it will affect the mucosa and cutaneous surfaces. Infection in a groin area may be a presenting sign, so a review of systems with the patient is important. Perlesh is a classic sign of diabetes in children, and it is seen with inflammation and fissuring around the mouth. Treatment for Candida infections involves topical antifungal or oral azoles. Candida presented as Candida paronychia is typically caused by Candida albicans, and Candida paronychia is seen pictured here to the right. With this infection, you will see erythema, swelling, loss of epidermis, and separation of the nail plate with nail fold retraction. This break results in a compromised seal between the nail plate and the nail fold, and the pocket of moisture that forms promotes the growth of bacteria and fungi. Chronic paronychia most commonly occurs in those who perform wet work like bartenders, janitors, or dishwashers. And treatment involves avoidance of further trauma and exposure to water, as well as a topical antifungal medication. Candida intertrigo usually involves the third or fourth web space of the toes. This area is likely to retain moisture due to occlusion from opposing surfaces of the skin. The clinical appearance is a white patch of skin, often with central peeling. You must differentiate Candida intertrigo from erythrasma, which is caused by Corynebacterium. It's a bacterial infection, not a fungal one. You need to also differentiate it from a dermatophytic infection, as well as a bacterial infection caused by gram-positive or gram-negative bacteria. So when you're examining your patient, always check between the toes for this type of presentation, as you would see here to the right, this lesion between the fourth and fifth toe. And in terms of treating this type of condition, you would offer dry gentian violet or betadine solution. You could also dispense naphthalene gel or clotrimazole solution. Toe web space infections may lead to inflammation and fissuring that can serve as a portal of entry for bacterial infection. So when you must check your patient regularly, check in between the toes, tell your patient to thoroughly dry in between their toes every time that they bathe, because this can become a serious infection in the diabetic patients. Candidal onychomycosis will present like this picture seen here in the nails. 5% of dystrophic toenails demonstrate the pathogen to be a Candida species. They present with distal yellowing or whitening and thickening of the toenail. Treatment is topical antifungals or systemic antifungal medication like terbinafine. Next, we're going to talk about dermatophyte infections. So these are superficial infections of the skin, hair, and nails by fungus. They're more common in diabetics. Specifically, the most common types of dermatophyte infections in diabetics is tinea corporis, which is a fungal infection involving the body surfaces, tinea pedis, which involves the foot, and onychomycosis, which involves the nails. The most common dermatophytes causing these infections are trichophyton rubrum and trichophyton mentagrophytes. Trichophyton rubrum will look like non-inflamed white powdery scaling or skin creases on the palms and soles, often with nail involvement, versus trichophyton mentagrophytes, which will look like an interdigital infection. It will present as maceration and superficial scaling with an active red border. The treatment for dermatophyte infections is topical antifungals or systemic antifungal medication. Pictured here above is what looks to be more of an interdigital infection caused by trichophyton mentagrophytes. And here you see some scaling of the digits. And more of a powdery appearance of the skin caused by trichophyton rubrum. Erythrasma is a bacterial infection that we all need to look out for when we're examining our patients. It's caused by Corynebacterium minutissimum, and its interdigital form is the most common cause of interdigital bacterial infection on the feet. So you will see scaling and maceration of the web spaces, which may be asymptomatic or pruritic, and they may occur concomitantly with dermatophyte or candida infection. Diagnosis to confirm erythrasma is performed with a Woods lamp. We have a Woods lamp in clinic. You let the patient know that you're going to be turning off the lights. You turn the Woods lamp on, and what you'll see as you look between the toes of a patient with an erythrasma infection is coral fluorescence, as pictured here to the right. And that is what the coral fluorescence looks like to confirm a diagnosis of erythrasma. Treatment for erythrasma includes prevention of sweating, friction, and maceration. And you want to limit how deep the infection, and those methods will help limit the onset of it and a more deeper infection. You can also use a topical or systemic erythromycin as treatment in addition to the prevention of sweating, friction, and maceration. The topical form of erythromycin is a gel. So you have the patient apply the erythromycin to the inner space daily. Bacterial infections are also seen with ulcerations. So diabetic foot ulcers are the leading type of morbidity in diabetes, and they're caused by diabetic neuropathy, PAD, and unrecognized injury. So increased glucose levels will cause white blood cell dysfunction, which causes bacterial proliferation, and thus infection ensues. Bacterial infections of ulcerations are typically polymicrobial, and Staph aureus is typically the most common bacterial agent seen, in addition to a variety of others. Of note is a biofilm or bioburden. So debridement reduces the biofilm. Biofilm is a block by bacteria against the antibiotic. So once the biofilm is removed, then the healing process of the wound can begin. Types of debridement include mechanical or sharp debridement, which is the best form of debridement. It should be the standard. But additionally, there's enzymatic debridement, which uses, for example, collagenase. There's also surgical debridement, for example, Versajet, or deep debridement, which are both done in the operating room, not done at clinic or bedside. So in summary, diabetes is a systemic disease with manifestations affecting every organ system. A skin lesion can be a marker for underlying internal complications. So it's imperative to ask your patients about the history of skin diseases and test them or refer them to a dermatologist if needed. The dermatologist is a skin specialist and can perform these definitive biopsies on any of these conditions and confirm a diagnosis of these skin lesions in a patient that's diabetic. It's important to do a thorough exam to determine and assess if any underlying conditions exist. And again, prevention is key in order to avoid infection or ulceration. Your diabetic patients should be seen regularly. Take note of the appearance of their skin, do a good dermatologic exam, and that way you'll be able to notice if anything changes. And that's the end.